let's get going here. I've got a couple of studies just by way of introduction that are to let people know about. One that's going to be starting very shortly is called Pioneer 3. It's a new stent study. The difference with this stent is that it's got, in addition to the drug, the polymer itself is biodegradable. So what you're left with is a bare metal stent. In the end, hopefully, one of the problems had been perhaps with later issues was the presence of the polymer on the stent after the drug had worn off. So this is actually a Chinese stent. I don't know if it's subject to the tariffs or not, but anyway, it's okay because China's paying for it. Oh, I'm sorry, I digress. And the nice thing about this is that MHIF is well compensated for this type of a study, so it's a good thing for us to be in. There's two other studies that one that's actively going on. If you could go to the next slide, please. And these are both very similar studies. This is Science 90. It's for 90 days of dual antiplatelet therapy. It's for people who are at very high risk of bleeding. They need, of course, to have an Abbott stent. The nice thing about this trial is that people can be enrolled after the procedure, not it doesn't have to be beforehand. So these are people that are very high risk for bleeding based on age, particularly the need for long-term anticoagulants for AFib and what have you. So that population base is extremely large, and it's that's 3 months of clopidogrel with the whatever it is, the anticoagulant or whatever, but based on age, renal failure, and whatnot. This has been ongoing. We've enrolled a lot of patients in this trial. We've done very well with it, so it's been good for us. And then when this ends, which shouldn't be too long, then we've got starting up the next one, which is even more exciting, is Science 28. So it's 28 days of dual antiplatelet therapy for people. The year of dual antiplatelet therapy originally came out of the fact that people with acute coronary syndromes tended to do better with prolonged dual antiplatelet therapy. Whether or not that's still the case with these new stents, that's unclear. And in stable patients, the original drug-eluting stent trials were 3 and 6 months of dual antiplatelet therapy. So they're trying to decrease that need and hopefully get an indication for shorter dual antiplatelet therapy in people who are at high risk for bleeding. Those are the studies. Thank you.
All right, well, it's my pleasure to introduce our speaker this morning, Michael Megali. Michael is, as you know, our second-year fellow in the Cardiology Fellowship Program, and one of the few and best ones who chooses intervention on his career path. So clearly he's very smart and knows where he's going. Mike has been an incredibly productive fellow we had. His productivity actually is almost unmatched. He's published more than 10, 15 papers already, including he's a master of the meta-analysis. He's got like 3 or 4. One came to Circuit Interventions coming out sometime soon. And he actually has published on aminophylline and several papers on CTOs. So he's been tremendous in his productivity and his enthusiasm, which is actually infecting the other people around him. So Michael is going to talk to us about one of the topics that he's been very, very productive. He actually had a webcast. He presented on this last week, which is about drug-coated balloons and how they fit in our contemporary practice. Unfortunately, we don't have for the coronary, but he'll give the answers to everything else. So, Michael, thanks again.
Well, thank you, Dr. Blakis. Can you hear me well? So, good morning, everybody. As Dr. Blakis said, today I'm going to talk to you about drug-coated balloons. And I know that not everyone would be familiar with the topic, and this is partly why I chose to talk about it. When they asked me to give grand rounds, I said, well, how can I teach those guys? What is better than a device that is not currently FDA approved for coronary? No one. It's used everywhere else, but not in. So I have no disclosures. And here are my objectives. We're going to talk about what are drug-coated balloons, a little bit of their history, and how they work. And then what are the uses in coronary artery disease? And then we're going to move on and talk about future directives and some recent concerns. So what are drug-coated balloons? I've been asked this question many times when I was telling people about my talk. And the answer is very simple. It's basically our old balloon that is coated with a drug. And the drug is usually paclitaxel. And the old paclitaxel, as you know, has very high pharmacokinetics. It can transfer to the vessel wall very easily. Some balloons use sirolimus, but most of the contemporary balloons use paclitaxel. And the drug is mounted on the balloon along with an excipient or a solvent. And they both form what's called a matrix coating. And the matrix coating is very important in how they function, how they work, and we're going to talk about that. And this is basically the drug-coated balloon. So why do we need them? In coronary artery disease, we used to do balloon angioplasty, bare metal stents. We had very high respiratory stenosis and repeat revascularization. And then when we had the drug-eluting stents, first, second, third generation, definitely decreased the respiratory stenosis, CLR, at the expense of stent thrombosis, prolonged use of dual antiplatelet therapy. So maybe if we can deliver the drug to the vessel wall without leaving a metal behind, would be the missing gap between both. So I'm gonna show you a case and just save the images in your mind, and I'll get back to it later at the end of the talk. So 64-year-old gentleman presents with non-STEMI, has DS to the mid-LED and diagonal. And sorry for having no EKGs for people who like EKGs. As we see here, we have some in-century stenosis at the proximal LED. We got some small vessels here distal to the stent and the diagonal. This is better seen on this view. And on another view of the circ, we have what, if I push the little bit, would be a bifurcation. Just save the images. Then top. So, quick history about drug-coated balloons. The idea of local delivery of paclitaxel to the vessel wall has been old since 1990s. They use porous catheters, double balloon catheters, even intrapericardial. But when was the first use of drug-coated balloons? So this is a paper by Schiller et al. In 2004. This was published in Circulation and cited by 95 patents, not 95 papers, 95 patents. And what they did is they were the first ones to mount paclitaxel on the balloon. They used ethyl acetate or acetone as a solvent. The concentration of the drug is pretty similar to what we use these days, 1.3, 2.5. Used in 40% arteries. What they found is 6% of the drug was lost in the bloodstream, 0% lost during inflation, and the dose in the vessel wall at 1 hour was about 8 to 17%. And they found impressive results at 35 days. You can even find a dose-dependent response. This is a control, blood and new intimal proliferation, and this is the ethyl, which is not a very good solvent, and this is acetone low and high dose, and you can see the high dose. Amazing response. So the acetone was more effective because they used some contrast medium, ipromide, and dipromide is used in one of the contemporary balloons used these days. And this is what they said in that paper. This technology could be helpful in the treatment of in-stent stenosis as an alternative to brachytherapy of stent. This was in 2004. So moving on to the mechanism of drug-coated balloons. So we know what they are, now how they work. So basically with the inflation, the balloon delivers paclitaxel to the endoluminal surface. And then the drugs stay in the vessel wall, deep layers of the vessel, allowing the endothelium to heal and re-endothelialize. And this is a huge advantage over drug stent, which keeps delivering the drug to the endothelium. So the question here, how long does the drug stay in the vessel wall? And on average, it's about 2 months, but that depends on so many factors. And that brings me here to what affects the efficiency of drug-coated balloon. Why does some balloons act very well and some others are not? And we cannot take a class effect of drug-coated balloons. First, the drug carrier, which is the excipient, is probably the most important. And this is a very complex figure, but basically what it shows is the optimum formulation with the excipient and the drug is what allows moderate rate of coating release, allowing the highest tissue uptake and tissue levels of paclitaxel. And if you have this optimized formulation, you don't need a high total drug load, and that subsequently decreases the downstream effect of the drug, or the amount of the drug lost in the blood. So what are the most common carriers used? These are the balloons that were used in the randomized control trials. The one drug-coated balloon is a very bad balloon. Actually, the excipient was dimethyl sulfate, which is not an eluting excipient. We'll talk about that in one of the trials. And then those are contemporary balloons. Frequently used in most trials. They use ipromide, which is basically contrast medium. The Medtronic balloon impact Falcon used urea, and this is the new balloon called Store. This is what's called Sapax. And the loading dose is 2 to 3 microgram per milliliter square. So what else affects the efficiency? The manufacturing process. Manufacturer has to ensure that the coating can withstand intra-arterial conditions, calcification and tortuosity and all. So probably the most important question, why drug-coated balloons? Why do we need them over the drug-eluting stents, and what are the main differences? And this table summarizes it, but I would say the most important difference is with drug-eluting stents, you have a low dose of the drug that is delivered slowly over a long period of time. While in the drug-coated balloon, you have a very high dose that is released very fast to the vessel wall and stays for sometimes goes away. In the drug-eluting stent, you have some mechanical support. So dissection is not an issue. You can tack it, no problems with recoil. While in the drug-coated balloon, it's still a balloon. Dissections would be a problem, recoil would be a problem. And maybe the most important is with drug-eluting stent, you leave a metal behind. But with the balloon, you just go in, deliver the drug, and you leave no metal behind. And this allows for a shorter duration dual antiplatelet therapy. They've been using 4 weeks of dual antiplatelet therapy instead of 6 months or a year. So basically, these are the main differences. There's from our paper. It's a smaller profile, promotes plaque reduction, promotes vascular healing, lowers stenosis, and shorter duration dual antiplatelet therapy. So moving on to deployment, and that's a bit of a technical part, but you have to prepare the lesion very well with balloon angioplasty. You have to ensure accurate vessel sizing, intracoronary nitrates, and after balloon angioplasty, if you have chemistry flow, no dissection greater than type B, and not more than 30% residual stenosis, you can go ahead. You have to know the drug-coated balloon can only be used for drug delivery and not for further angioplasty. And accurate sizing is very important, as you see in this figure. If the balloon is smaller than the vessel, you increase the downstream dose of the drug given left in the blood. You should not touch the balloon prior to introduction, and it usually takes prolonged inflation, 30 to 50 seconds. And if you find this after using the balloon, dissection C or higher, it is recommended to do bail-out stenting, second generation. So talk about what they are, how they work, what are their drawbacks. So we talked about one of them, which is that drug-eluting stent gives you better angiographic outcomes because of the mechanical support. The other part is some people argue that stenosis due to new intimal hyperplasia is slow. So drug-eluting stent might have an advantage here by slow and continuous release of the drug instead of delivering the drug one time. So now moving on to the second part of my talk, which is uses in coronary artery disease. None of them is approved in the U.S., but they are used everywhere. They have been tested in so many conditions, but we're going to focus on just a few of them. In-stent stenosis, small vessel disease, bifurcation lesions, and diabetic patients. So what about in-stent stenosis? Guidelines say in U.S. you can use balloon angioplasty, bare metal stent, drug-eluting stent, while in Europe you're allowed to use drug-coated balloon or a drug-eluting stent. And it makes sense, right? You have in-stent stenosis, you don't want to add additional metal layers, which makes things more complicated later on. So what does the data show? This is again Scheller in 2006, paper in New England Journal of Medicine. This is 52 patients randomized to drug-coated balloons or balloon angioplasty with in-stent restenosis. As you can see, drug-coated balloons are superior. So what about drug-eluting stents? Again, this is the Desire 3 trial, and they randomized 402 patients. So paclitaxel-eluting stent, paclitaxel-eluting balloon, or just balloon angioplasty. As you can see here, the balloon and the stent are comparable, and they are both superior to the balloon angioplasty. Moving on to the RIPS 4 trial, and this one used some contemporary devices, the sequence-please drug-coated balloon and the Zions. And this is 189 patients with bare metal stent and stent restenosis and a 12-month comparable. Again, SEDUCE trial, 50 patients randomized to sequence-please and Zions. And what they did in this trial, they got OCT at 9 months. And that's kind of expected. The Zions did better in the lower percentage of diameter stenosis, but this did not translate into any clinical outcome. And then comes the trial that sets everyone back a little bit, which is the RIPS 4 trial. This was published in 2015. 309 patients with drug-eluting stent and stent restenosis, which is what we see. They, again, did randomize them to sequence-please and Zions. 24% of the patients had more than one stent. Some people say it's high, some say it's low, but we see all these patients, right? So at 12 months, the Zions was superior in terms of TLR, TVR. And what they did is, at 3 years, they published the follow-up. And this is a landmark analysis, so they excluded the first year from the analysis, and at 3 years, they are both compatible. And again, people didn't give up. This is the DARE trial, 237 patients, drug-eluting stent or bare metal stent and stent restenosis, sequence-please drug or Zions, and they are both comparable at 12 months. This is a run-of trials, and of course, a lot of meta-analyses were done on that topic, and basically what they got to is drug-coated balloons are inferior in terms of TLR, but at the end, MACE rates equivalent. And this can be due to many things: the advantage of giving only 4 weeks of dual antiplatelet therapy, the advantage of not adding another metal. And that leads us to this study, which is actually a very smart study. This was published in 2018. And this study, they got 304 patients, retrospectively analyzed them. They divided them into groups of 1, 2, and 3 metal layers. And what they did is, what they found is, if you have 1 or 2 metal layers, your outcomes with drug-coated balloons are comparable. But if you start to have 3 metal layers or higher, if you use a drug-coated balloon, outcomes are not that good. So we can say, or we can suggest that it might make sense if you have 1 or 2 metal layers to use a drug-coated balloon before moving on to adding a third metal stent. So a lot of debate on this one, but it's approved in Europe for drug-coated balloon for in-stent restenosis. So moving on to the de novo lesions, mainly we're focused on small vessels, but this is a trial by Ron Waxman, published in 2013. 103 patients, this single arm used drug-coated balloon for de novo lesions, not in-stent restenosis. The reference vessel diameter was of 2.4. And these are the outcomes at about 7.5 months. 2.9% TLR, 6.9% TV. So not so bad. This is a huge registry published in 2019. 66.9% of them are de novo lesions. And what they found is when they use drug-coated balloons, the de novo group does better in terms of TLR, and there is a trend towards doing better in MACE. So it works in de novo lesions. So what is the rationale of using it in small vessels? And before I talk about this, small vessels is defined by so many trials, so different cutoffs. So people might consider 2.5 millimeters small vessel. Some trials go up to 3 millimeters as small. So the drug-coated balloon, it makes sense to use in small vessels, right? So small vessels are usually diffuse, long, and complex. So with the smaller profile of the drug-coated balloon, you can get. And when you avoid a foreign body implantation in a small vessel, no matter how good your stent is, small vessel is small vessel. It doesn't have the space to accommodate any new drop. So it might make sense, but what does the data show? This is a single-arm registry in 2010, 108 patients, reference vessel diameter 2.35. TLR was really high at 1 year, 12%. You can say people were starting to use it, and 30% of those patients had bailout stent, which is they call a dissection, not suboptimal angiographic outcome. So they stented 30% of those patients. This is another single-arm registry in 2014. 479 patients is a big trial, and they define small vessel as less than 2.75. Actually, 23.5 of them were PCS. Very low bailout stenting rate, and TLR was only 3.6% at 9 months. And that led to some randomized trials. So I'm starting with this one because this is the only one that compared drug-coated balloon versus balloon angioplasty. And they randomized 133 patients, 2.75 millimeter reference vessel diameter, second laser balloon angioplasty in 6 months. Lower binary stenosis, this is impressive, 13.3 versus 42.5%. Did not translate into a statistically significant difference in TLR, but probably because of balloon. So what about drug-eluting stents? And here it becomes very challenging. This study in 2010 almost killed the idea. 57 patients, vessel diameter 2.75. And the reason is they use a Dior-1, this balloon that does not have any eluting excipient, so probably there was not much paclitaxel in the vessel wall for using Dior. They compared it to first-generation drug-eluting stent. This stopped early because drug-eluting stent was way better in terms of MACE and angiographic stenosis. This study I have criticized so much because they used the Dior-1, they had a very high bailout stenting rate, and lesion preparation is not optimal. And lesion preparation is very, very important when the drug-coated balloon. And then comes the Bello trial in 2012 that saved the idea. 182 patients, reference diameter less than 2.8. Here they used the impact Falcon, compared it to first-generation drug-eluting stent. They only had 20% bailout stenting, still high, but at 6 months, everything was similar. Binary stenosis, TLR, and MACE. And then comes this huge trial published in The Lancet in 2018, and it is expected that this trial would change the European guidelines, that they would adopt drug-coated balloon small vessels. They ran 758 patients, and reference vessel diameter was less than 3 millimeters. They used the 3 millimeters as cutoff. Again, complete, and they used drug-eluting stents, second generation mostly, and 24% of them were first generation. Only 5% bailout stenting, and in 12 months, very similar, 3.5, 4.5, and 7.5, 7.3. And then finally, another study, this small non-inferiority study. They used the Restore drug-coated balloon, talked about, and they compared it to the Resolute, again, second generation drug stent, 9 months. Diameter stenosis is similar at 1 year. Target lesion is similar. And this is a summary of the trials that has been done on the topic. This is from our meta-analysis, compiling both randomized and observational studies, and drug-coated balloon is way superior to balloon angioplasty in terms of TLR and binary stenosis, and compared to drug-eluting stents, they are very. So what about bifurcation lesions? And bifurcation lesions are problems, mainly side branch. This is what increases your TLR rate, increases your MACE rate. And the studies here start to get lower and lower, and more studies are definitely needed in that topic, and they will come. So Again, this is from our meta-analysis on the topic, only 3 randomized trials, very low numbers, and we have 1 observational study. And what they did here is that they used drug-coated balloon versus a balloon angioplasty in the side branch. So to your bifurcation, you assess your side branch, and if the side branch is angiographically not very optimal, they use balloon angioplasty or a drug-coated. And the thing is, most of these lesions, bifurcation lesions, 70% of them were Medina 001. And for those who are not very familiar with Medina classification, first number is the proximal main branch, second number is the distal main branch, and third number is side branch. So 001 looks like this, which is why some people might not be considered as bifurcation. And what we found is that 9 months, less late lumen loss, mean difference minus 0.2 millimeters, and clinical outcomes are similar. So there is a strong trend towards decreasing binary stenosis, but this might need more powerful studies and more studies to. So moving on quickly to diabetic patients. And again, the diabetic patients, it really makes sense to use drug-coated balloon in diabetic patients. And the reason is, in diabetic patients, they have small vessels, they have long lesions, they have complex lesions, but most importantly, they have the milieu of inflammation that accelerates in-century stenosis. So if you leave no middle behind, this allows for a very good outcome in diabetics. But what does the data show? Actually, that is very, very scarce. There's only 1 randomized trial, 2 observational studies. Bill-out stenting rates were very high. 1 of the studies used provisional stenting given. So outcomes are lacking in that topic. Only 378 patients, and this is from our meta-analysis on the topic. As you see here, no difference, statistically significant difference, but there is a strong trend that drug-coated balloons might outperform drug-coated stents, 7%, 17%, in terms of binary stenosis. So, done talking about that, if we go back to the case, I'd say that, and I saw this case, said, well, this might be perfect for a drug-coated balloon. You have in-century stenosis, small vessel, and you have a bifurcation. Well, still need waiting for it. So what about future directives? And what moves the future more than money? Why isn't it in the U.S.? So this is a cost-effectiveness analysis using drug-coated balloon in coronary artery disease. This is an abstract presented at TCT, and they use very complicated computational algorithms to come up with these numbers. So they said in case of bare metal stent in-century stenosis, if you use a drug-coated balloon up front, it might be a little more costly. But over 12 months, it actually costs less, and it's more effective in terms of life expectancy. And that's the only study we find on the topic. So coming to the U.S. for CAD, you know it is here, and vascular surgeons use it for peripheral, but not for coronary disease. So why has the FDA been reluctant to approve it? So the regulatory bar is higher. They want larger scale clinical trials. And most of the trials have been only powered for surrogate outcomes. And there are some safety concerns that we're going to talk about. So I asked myself, I even emailed Medtronic, I emailed other companies, and this is the response I got from Medtronic. There are a lot of regulatory hurdles, and it might not be worth it for the small market size because it's only filling the gap. So not aware if it's coming soon, but we hope so. So I'm just going to spend a few minutes talking about these recent concerns because it made it to the media. It's very, very important these days. This is a meta-analysis published in JAHA in 2018. And they basically said that all the paclitaxel-coated devices in femoral popliteal disease is associated with mortality. And some of you might have heard of that. 2 years mortality is higher, 5 years mortality is higher. And everyone freaked out because it's used every day. Yes. Some of the vascular surgeons here put a hold for that. But criticized so much, especially after they said that paclitaxel dose-time product, if you have a higher paclitaxel dose, you have a higher risk of death. So this is what the answer was. They said that these studies did not have the death uniformly recorded. The causes of death were missing. And some of these trials were really well conducted. They have a clinical events committee that reviews the causes of death. And they didn't find any correlation. And of course, the most important is no mechanism. Fused paclitaxel, why does it increase mortality? And then finally, a lot of people acted on it. There is a meeting in Germany in 2019. All the companies came, they presented the patient-level data that disprove them. And then this is a JACC paper published in 2019, patient-level meta-analysis from 4 huge registries and 5-year mortality, no difference. So the concerns might have been, defied, but I don't know how long that takes effect on the FDA. So to summarize, drug-coated balloons are good. I hope I convinced you. The smaller profile, all this good stuff, short duration, dual antiplatelet therapy. They are comparable to drug-eluting stents in small vessels and